Good morning, everyone. Welcome. We're going to get started with July 14th EMCC meeting. I want to start out calling the meeting to order and start out with a roll call with our EMCC members. I'll start to my left and then work our way around for roll call.
John Burley, EMS Agency Medical Director.
Steve Brooks, EMS Agency.
Scott Houchins, Lance Fire.
Sam Ballesteri, retired EMT.
Deborah Hopgood, EMS Agency.
Jeff DeAndrea, EMS Agency.
Teresa Rios, EMS Agency.
And we'll move over to our folks on Zoom. We can start out with the Vice Chair, Tina.
Tina Nieto, Law Chiefs.
Roxanne Seepersad, EMS Agency.
Jody Schaefer, Citizen Rep.
Nicholas Berger with the ambulance provider. Hi, everybody.
Paul Wood, City Managers.
Jim Langford, BLS Fire.
Roger Reinhardt, CAL FIRE EMS.
Leanne Magoski, Emergency Communications.
Nick Greenson, Flames Valley.
Tiffany Wallace, Me Memorial.
I think we got a few more people left on the Zoom. If you don't mind introducing yourselves.
Yeah, good morning. This is Jeff Warner, Program Director with CalStar.
Thanks, Jeff.
Dave Craddock, Monterey County Regional Fire.
Welcome, Dave.
Good morning, it's Cambria Higgers. I'm with Mercy 20.
Morning.
Gavin Panholzer, Fire Chief, City of Monterey.
Welcome, Chief.
Harry Robbins, Citizens Rep.
Good morning, Harry. I think we have Liz and Sandra left.
Liz Vega, AMR.
Sandra Flores, AMI.
Okay, great. I think we got everyone. Thank you, everyone, and welcome and good morning again for our EMCC meeting. And again, Tino Ariano from AMR Operations. I'll be the chair for the next few months. So again, welcome everyone. Bear with me. I'm new to this, so I'm looking for guidance and direction as well, and some corrections as needed. So with the roll call completed, we'll go next to public comment. Public comment here, any member of the public may address the committee for any period not to exceed 3 minutes on any issues not on the committee agenda. The EMCC will listen to all communications but not take any action. So I open it up to public comment for 3 minutes. Anyone can address the committee. Seeing no raised hands, seeing none here in the building, we'll go ahead and move to the next section. Approval of the past EMCC minute meetings. Minutes have been sent to everyone via email, and I'm hoping that you guys got a chance to look at them. And if there's any corrections, edits, any issues with it, let us know.
I move approval of the May 12th meeting minutes.
I'll second that.
So we have a motion to approve the minutes and second by Jody. Do we have any discussion on that? Seeing none, I will
Roll call vote.
Roll call vote.
And I'll go do the roll call.
Okay.
Tino Ariano.
Aye.
Tina Nieto,
Aye.
J.C. Carlos Spencer. I don't think so. Sam Clemic, I didn't see. Jim Langborg,
Aye.
Harry Robbins,
Aye.
Jody Schaefer,
Aye.
Luz Garcia, did you come in? Didn't think so. Paul Wood,
Aye.
Dr. Greenson,
Aye.
and then Greta and John, I don't believe are here. Did I miss a alternate for member who's not here? Okay, motion passes.
Okay, great. The ayes have it, and we'll move to next two reports. We'll start with the Medical Advisory Committee, MAC.
Back and ops are both written reports, unless someone
Okay.
has comment.
Okay. Any comments on those two reports? Seeing none, we'll move on to the next one with Teresa Rios for the EMS agency report.
Thank you, Chair. Your agenda packets include a staff report highlighting some of our system accomplishments as well as projects that we have in progress. I don't want to highlight everything there. I'm going to pick a couple and then others are going to be covered during the meeting. But one of the items is our annual report was presented to the Board of Supervisors and received compliments, both the presentation of the information as well as the amount of work that we have accomplished. I cannot remember the last time that we actually did a presentation to the board on the activities of the agency, so it was very well received. The staff report also mentions that we have filled EMCC positions. The same is true for our MAC and ops committees. Our goal has been to diversify representation to reflect the community and the geographic areas that we serve. We have the remaining vacancies. The EMS agency will continue to work on filling the mostly alternate positions, and we will continue to report on our progress at our next meetings. In terms of activities, we are working with our mobile app developer to provide real-time push notifications to our users. We are also reviewing our policy and protocol cycle. We believe that there are some efficiencies that we can realize there. And we definitely don't want to do that just internally. We're going to be reaching out for stakeholder input, which is very important for our policy and protocol cycle to be successful. We are expanding our EMS agency capabilities. We are engaged in training of staff, and we are also trying to make sure that we continue to engage with our stakeholders, and Dr. Burley has done some trainings. And so we are planning to have regularly scheduled trainings in the coming year. Deborah will be reaching out for some topics, things that the system needs. So we definitely need your input on that. We are starting to work on our strategic planning. Our last strategic plan was from 2017, so it's definitely time for us to do that again. And eventually our goal is to engage in a system-wide strategic planning. Yes, the rest of the items, I think I want to make sure that are covered by the EMS analysts who have done all of the work on that. And that's my report, and I would be happy to answer any questions.
Okay. Don't see any questions. Thank you, Teresa. Thank you for that report. We'll move on to the next report, the EMS Quality Improvement Program. Deborah Hopgood from the EMS agency will provide a report.
I just want to address a few of the issues and different programs that we've been working on since the last meeting. We're continuing to move forward with the trauma patient PCR standardization project. The first meeting for that group will be scheduled or is scheduled for Monday, July 19th from 1 to 3. If anybody hasn't provided a representative for their agency, please feel free to reach out to me with any information on that. The project between ESO and SVMH is also moving forward. That's a project to incorporate PCR data directly into the files at SVMH, patient care records, and then to provide follow-up information within ESO for our field providers. They are working on establishing a go-live date, and the testing so far has gone well with that project. The NMC Trauma Center designation agreement was approved by the Board of Supervisors yesterday, so that will go into effect and provide coverage through 2026. We are still working with the IT departments at Natividad and our own internal IT to get our connection to Trauma One established to provide direct patient follow-up information for the trauma patients transported to Natividad. We're also working on contracts to put in place follow-up for STEMI and stroke and cardiac arrest patients. So those contracts are both in progress and will go to the Board of Supervisors at the September meeting. On a related note, staff training wise, we all recently attended the STEMI and stroke summits as well as the MSAC conference, and we're able to bring some ideas from that back to the system for some improvements. And those will be discussed in the appropriate QI committees. We're also working on core measures. Those are due to the state on September 10th. So those will be reported out at the next CQI tag meeting. Dr. Burley is working on some training for our base hospital physicians to orient them to the EMS system and their responsibilities when answering the phone for the EMS providers. And we also held our first working group meeting of the HEMS working group focused on air ambulance information. So we had stakeholders from the EMS agency, Mercy Air, and CalSTAR participating in that. We talked about some things such as incorporating their PCRs directly into ESO to allow for better access to data, as well as some different data sources that we can access and what information we should be looking at. So our next meeting is scheduled for this Friday with that group, and we'll be narrowing down the data points to look at and determining the best sources for that information on the go forward. And then as Teresa mentioned, I will be putting out a survey looking for some input as to classes for Dr. Burley to offer in the future. We're looking towards scheduling the next class in October. So more information to follow on that. And that's everything I have.
Okay, great. Deborah, thank you so much for that. That's a lot of work that's going on. So any questions for Deborah? Okay, no, seeing none. Thank you. Thank you, Deborah. Well, next report on the agenda is emergency response to COVID Mohawk activities with Jeff.
Hello, everybody. I'm not sure where I got up on the podium last time when we've all been sitting. We're at a very an inflection point, you might say, with COVID. We are seeing a little uptick in cases right now, which in the big picture is minor compared to where we've come through the last year. We have recently, this is yesterday's data, which is thus 2 days old right now, 7 people admitted in the hospitals in the county here, 2 in the ICU. And just in contrast, for the past 10, 12 weeks, we've had just a few hospitalized and nobody in the ICU. So the situation's been really under control. It still, by all means, could be considered under control. Although we are seeing that little uptick, and we owe this pretty much to the Delta variant, which has wreaked havoc elsewhere. But right now, more than half of the new cases in California are Delta variant viruses that have been identified in labs as that variant. And we should note that nearly all of the new Delta variant cases are occurring with unvaccinated people. And we are pretty much in this county, and I think, for the most part statewide, the vaccination rates have, they're really plateauing. People will continue to get vaccinated, but we're not going to see tremendous increases, I doubt, unless, the new variant were to hit the unvaccinated population terribly hard, and maybe that's a motivation. But at any rate, I think that is sort of plateaued, and even though the uptick is occurring, the numbers are still very manageable in terms of the healthcare system. Over the past year, I just want to acknowledge all of many organizations and agencies countywide. We've really been successful for the most part. There's been challenges and hiccups, but we've done a good job at staying ahead of the curve here. And I wanted to highlight some of the EMS agencies. We're very proud of, what we've done, our role over the past, 18 months, which started with monitoring daily news and reports from the CDC, the CDPH, and the EMS authority. That's been going on since December, January, continues to this day that we've receiving various reports from organizations. The EMS agency first responded with some dispatch screening procedures and new questions for emergency medical dispatchers to get a sense of what's going on in the community, and to protect fire and EMS and law and their responses. Going to residences with people who are showing symptoms or reporting symptoms. So we started doing that as early as March, and that's continued all along over the past year plus, with just monitoring those procedures and tweaking as necessary. Through the agency's MOOC role, as everybody knows, because just about everybody here in the meeting has received some equipment one way or the other. We've distributed state-supplied PPE and other equipment, oxygen concentrators, ventilators, CNAs, LVNs, RNs. I shouldn't refer to staffing as equipment, excuse me, but all manner of equipment and supplies, PPE, for the longest time. This is a unprecedented duration for a public health emergency. So what's been developed in terms of the infrastructure for state supplied support has it's never been more robust than it is now. I think that's something to be optimistic about going forward. The agency, something we're all very proud of as well, is worked with the state and local fire agencies to create a LOSOP, an expanded scope of practice for EMTs and paramedics to first administer COVID tests and then COVID vaccines. And I think we've made a difference there with the whole vaccine deployment process. Just wanted to say that I'm proud of the work we've done in the past year, and we've got a lot done, and we're a small team that does big work, and we've but still as proud as I am for us as an agency, we've relied on everybody, and I just go back again and again to say there's been a lot of cooperation and collaboration, and none of us could have done this alone. And any individual agency, even a hospital, we'd all be would have fared far worse without all the other stakeholders and all the cooperation that's taken place in the county over the past year. So I just wanted to acknowledge everybody here in every possible way. We should all, I don't know, pat ourselves on the back. I think we've averted a situation that could have been, it has been disastrous for many families, of course, but we really did keep everything from coming apart at the seams. We got close, but we've handled it here. And I think as a integrated healthcare community, we should not forget that for future challenges that we can do this. So thank you to everybody.
Thank you, Jeff. Any questions for Jeff from our folks Zoom? Don't see any hands raised, and any from the group here for Jeff. I'd just like to say, Jeff, no, thank you. You guys have been really responsive as the EMS agency on all requests. I think your guys' accessibility was phenomenal. And I think the response that the agency gave to the providers was great. So thank you. That's a lot of work. Okay. Let me move on to the next report. Contract compliance working group, Roxanne, or I believe.
Yes, I'll be taking over the report today. Roxanne was not able to provide the report, so bear with me because I don't do this presentation all the time. And I probably will not do, well, actually it was Kimberly's presentation that was going to be covered by Roxanne, but life happened. I'm just waiting for that. To bring it
I think we're okay to say if they have any questions, they can send them up on the comments or raise their hand as well.
Sure. Okay, so this is our contract compliance presentation. They would have been presented by Roxanne today. So we start with our report on response times reported for the different priorities in the county. This one is our overall AMR response time compliance. What you can see is that for the most part, priorities 2 through 6 do really well consistently. They are above 90%. We continue to struggle with priority 1, and we are working with AMR on some of the solutions. I think there's some of the issues that have been identified, have been discussed at this committee at length, which has in part to do with the change of the that we made to MPDS, implementing that call interrogation. In that process, where the shifting of the number of calls that used to go into priority 1 were shifted to priority 2, so it made the bucket pretty small. Staffing issues, COVID, fires, all of those affected our response to compliance in 2020. One of the things that you can see when we compare the months of May 2020 and May 2021, we response to compliance for priority 1 is slightly lower at 87%. We did meet response to compliance in priority 1 in April, and we got in what is it, February? Yes, and we got really close in March at 89%. Now, one thing to remind the committee is that even if AMR hits 89.9% in their compliance, there's no rounding up in the measurement of the compliance. And I believe that was one of the things that happened. If I don't know, if, Tina, if you remember, that we said, you are just right there. Right? They were off by, just a smidget. Next one. When we start drilling down into the different response areas, we see the same fluctuation with the response times in similar dips when it comes to priority 1. What we see here when we compare the month of May 2020 and 2021, we do see that the response and compliance increased in that month. And we also see that we made response and compliance in April. And again, we got really close in the month of March. Next. For the yellow zone, the priorities do really well. And this is where we start to see some of the priorities not being reported every month because of the 100 call rule. If we don't reach 100 calls in the month, that priority will not be reported. But we see the same thing, priority 1 still in some months falling under 89%. In orange, this is another area, fewer calls, even fewer than in the yellow zone. So you see where the priority, the calls are not being reported in certain months, but in this particular case, all of the priorities that are reportable are above 90% compliance. One of the things that, because priority 1 is of great concern to all of us, those are the high acuity calls. And when because we continue to see the calls drop below the 90% threshold, even though we understand the reasons why that is happening, we wanted to get into the data a little bit more just to see, well, what can we tell about these calls that we can present information and see what, if anything, we can do about it. So we're starting to do a drill down of the priority 1 calls just to see where are these calls or how late are they, and see what opportunities there are for us to do something about it. And that report is going to be provided by Steve. After he does that report, I will continue with the rest of the presentation.
All right. Thank you, Teresa. Anything else on that? I think we're jumping over to MPDS or dispatch.
Priority 1 drill down.
We inserting something in
Okay.
there, Tino, if you don't mind.
Yeah, sorry.
The EMCC has requested information on priority 1s. As you saw in the previous slides, priority 1 has been the challenge for compliance with the 90th percentile response times. And so we were asked to do a drill down into the priority 1 data. And so this report, which I can say was very well done by Kimberly. I wish she was here to be able to present it and look good for it. This report's going to do a couple of things. We're going to look at the number of late calls. We'll look at how late they are, as well as some of the results as far as what happened to the patient, for these priority 1 late calls. So we'll start with the methodology, and I'm not going to go into it. If you want to drill down into the methodology, most people's eyes glaze over. But basically, we took all the priority 1 calls that did not come up as on time, and we've lumped them in from January to May of this year. So next slide. So here's a summary slide, because I think the larger numbers show the more accurate picture. You will notice that we had had 125 late calls over the 5 months, and that the majority of them were in, of course, the green zone, which would be expected because there's more calls in the green zone, and then progressively less in the yellow and orange. The late intervals, about a third of the calls were less than a minute late. So they were seconds after the requester's required response time or the response time standard. And then the greater majority were 1 to 3 minutes late. So we had about 79% of the calls against the compliance standard were late. And then progressively more or fewer were 3 to 5 minutes, and then 5 or more minutes late. And as this was being looked at, one of the bigger issues that we found was it's really had to do with distance. We all know that Monterey County is a large county, very spread out, and to cover that for the primary response, for the first call in that area, the ambulances are spread out throughout the county, which means that for a second call within an area, the ambulance is coming from a point that was intended to cover a separate area. We just don't have the resources to double up in many areas. Nobody can really afford that. So that's the main cause. That's why you see the distance with the unit not at the optimal post, meaning that they were coming from somewhere else, is the largest factor, at least half the calls or more than half the calls, why the unit was late. Next slide. So this is a breakdown of what happened to the patient. We see that a majority of the patients were actually transported. Most of them were transported code 2. About 20% of them were transported code 3, and then another 20% or so of the calls were not transported for various reasons. And of the code 3 returns, we can see that the majority of them were the ambulance arrived within a minute of the standard that we had set for the response time, and then progressively less, which makes sense because the The calls themselves were fewer late calls, so therefore we would expect fewer code 3 returns from that. Next slide. So the next slides are a breakdown by month to see, how it can be affected. Relatively small numbers, of calls in the different zones, as it pretty much matches up with the summary for January. Number of late calls, intervals. And again, distance was, again, the bigger issue. It's a large county, and we've spread the ambulances around to optimize response for the primary call. Second calls are in many ways problematic. So here's a breakdown of, the transport, most transported code 2, a few transported code 3, and then not very many in January were late or were canceled. February shows, again, very much the same kind of progression. Most calls in the green zone, few in the yellow. There wasn't anything in the orange zone this month. And as far as late, again, vast majority within 3 minutes of the response standard for the zone. Next. So February, we can see majority transported code 2, a few transported code 3, and as expected, some were not transported at all. And you can see, oops, I'm sorry, that was me looking at the screen. As you can see, this one also is in the gray box. You'll see if the transports, they were close, very close for how late they were, and not being very late at all. So this is March. Same thing. It's a little bit inverted in that the 0 to 1 minute had been larger. This one, as expected, each month's going to be different, with more 1 to 3 minutes. Same kind of stats as we see. Again, same stats. Most patients transported, vast majority transported code 2. There's still some that were not transported at all for various reasons. April, again, it balances out as we might expect on occasion. And at least April had as a percentage, a few more that were 3 to 5 and 5+ minutes, but still in the overall picture, the ambulance is getting there within just a couple minutes, which is a function of our system. We're putting ambulances to cover everything. And then April, you can see most transported code 2, a few code 3, and a few not transported. May, significantly, a little more on the 1 to 3 minutes, but again, vast majority within 3 minutes of the response standard for the zone. You can see, on the most are in the green zone as with each month. And again, distance is the primary factor as to why the call wasn't responded to according to the contract standard. May, vast majority code 2 again. Of the code 3 transports, the majority of those had a, less than a minute, longer than standard, all as we would expect. And that's it. Any questions on this prior to one drill down report? Thank you very much.
One real quick question. What do we know how the staffing and number of ambulance units per day that are in service affect the late call response?
Yeah, we do, Dr. Greenson. We actually have been reporting our numbers and staffing to the county, but usually we peak at 19 daily. But with call outs or shift change or something that occurs, we usually about an average about 16 a day deployment at peak. But again, we've been adding additional BLS units as we're able to partner up 2 EMTs with no partners. And we're able to progress through that in a day. So again, some days are good, some days not so good, because we will get last minute requests from Laguna Seca standbys or out of county transfers, which then pulls these units out of the county for a duration of time. So, but
And just to add, since we started getting those daily reports from AMR regarding their staffing, part of the reason why we were asking for those is to see if we could see a correlation with a number of late calls. And we can't really say that at this point. We're going to continue to watch the data to see if we identify some patterns there.
Yeah, our staffing has been our prime focus, especially with retention and recruitment. I know Mike can probably speak to that because we've been working aggressively with other counties and really putting out different bonuses for folks to come work for us and just doing all different types of new ways of thinking of retention and recruitment for folks. But it's an ongoing process.
No, listen, I completely understand that there are some very significant obstacles to staffing, recruitment, and retainment in Monterey County for medics. But I'm curious, and it would make sense to me that would correlate with the late calls. So I'd be curious to see that data to see if we can solve the staffing problem, if that's going to, fix the priority 1 late call response problem.
And it is our goal to expand on this report. At this point, like I said, we have been reviewing the data, trying to see if we can identify what patterns we can identify. Once we are ready and sure of the data that we're bringing, we'll expand this report.
I would greatly appreciate to see that data whenever you guys are comfortable with that.
Thank you. We really hope that you find the drill down of the drill down report helpful. I think that one of the things that knowing that even though a call may start as high priority, when we start to see that how they are being transported back and how many are being canceled, and when we end up with a much smaller number of calls that were late, that were code 3.
We disagree a little bit on this because, I love the belief that just because, when the delayed response didn't lead to bad patient outcomes, that there's not a risk for that going frontwards. I think there's a huge risk. And that's what I'm concerned about. So I still think, even though it's great that we haven't had any, significant adverse outcomes, that's my concern.
I totally understand, Dr. Greenstone, not disagreeing with you. I'm just simply saying that once we drill down, then we can see a clearer picture as to what happened with those calls.
And I completely appreciate the drill down. That's some very good information. And thank you very much. I'm sure it took a ton of work.
Thank you, Dr. Greenstone.
Again, this is Mike. And if I can just point out again, certainly just for clarity, staffing, obviously all of those things certainly can contribute, to the number of ambulances that you have on in a day. But I do want to point out that, when you look at the actual standards, the standards in priority 1 and how many late calls that we can have a day, it's still less than 1 a day. And it is just a standard that is very difficult to meet, even when we're fully staffed and best options. And we're aggressively doing everything that we can to make sure that we're meeting our full staffing schedule, all of those things. But it's a tough one. So it's something that we've been working on with the EMS agency, and we'll continue to study and try to find ways to make improvements. But I think the standard itself is going to be a challenge. So anyways, thank you.
Okay, thank you. Thank you.
Okay, if there are no other comments or questions, then I'll finish the presentation on compliance. This next slide that is on the screen, on the current slide. So after the responsive compliance, next, yes, so this is the EMS dispatch performance. This is an area where AMR does consistently well. Per the agreement, the call should be processed within 59 seconds. And as you can see from the chart is that they're always well below that 59-second time. This is the NPDS performance. We have been measuring how many calls go through the call interrogation process. What you see from March, April, and May of 2021, the committee endorsed a change in the way that we calculate NPDS performance. We are keeping, we are showing both ways, the old way and the new calculation, just until we got used to it. If everybody's fine moving forward, we will bring the chart showing only the current way of calculating NPDS performance. But what we see is that prior to the change, the percentage of calls going through call interrogation was in the 50% range. We noticed, from last year, May and June of 2020 to later in the year that number had even dropped. But I think given the fires, given the COVID, that might have had something to do with it. What we noticed this year is that in March, with the new calculation, for example, we hit 68%, but then it started to drop. What we know that happened here is that in April and May, there were issues with the phone lines at AMR dispatch. And AMR was even transferred back to the call center at Natividad. So that probably explains some of the lower numbers that we see in April and May. We will continue to watch the data and we'll continue to report.
I have a question. With the 50 to 60% EMD of calls, is there an opportunity to have EMD done in different places too, so we can get a higher percentage of EMD completions?
Well, we believe that we're going to be able to reach a higher percentage. Part of the reason why the percentage wasn't as high is, during COVID, it has extended the time that it takes to process the call. But I think that we're going to be able to reach a higher percentage. The other thing is that there are calls that are still in a bucket labeled MED that we can't put in any and I'm sorry, I'm rusty on the data right now. So we're starting to drill down into those calls and see if we can start now putting them in different buckets to make sure that they are counted properly. But in terms of exploring options, that agency is always exploring different, better ways of doing things.
It would seem there's other efficiencies where other systems have EMD contracts and then they come back to the call center. What's our standard benchmark for EMD? Are we looking at 80%, 90%? Is that the goal?
There was no standard set because we wanted to see what the change did. But I think that I think if for some reason 75% is what is in my mind. But officially there was no, that I can recall, no standard set. But based on other systems, I think that that's what we're looking at. But I think that we will reach that. APAT times. What we see on this chart is some minor fluctuation on the APAT times. This is a measure that measures the 90th percentile. There was some upticks in April and May for the different hospitals. The upticks didn't happen at the same time. We do see that NMC tends to have the higher APAT times, and I think that that's not unexpected to see. Once we saw the upticks, we started looking at the data. A report that is sent to the state that is APAT 2 report, I think it's called. And what we saw is that the extended APAT times tend to happen on a single day within a few hours of each other. They seem to be a small number of outliers, and it's likely due to the high influx of patients into the ER during those times. even though they are small numbers, they do affect the 90th percentile times reported. But even with those fluctuations, the APOT times continue to be within a reasonable range. And this is oh, sorry.
Just one comment on that. If we look at the previous slide there, we're relatively consistent except for NMC. And I have to think that as we've looked at this over the years, APOD times have an impact on response times. If a unit is tied up at the hospital, that means there's probably a move up someplace within the system, and it stretches our resources. So going along with what the doctor said earlier, I'm wondering if there's any correlation, and it would be very hard to prove, but is there a correlation between higher APOD times and our response late times? Does the fact that an ambulance is tied up at the emergency room impact our late times or cause late times? I don't know. And whether it was probably be fruitless to go and chase that down. That's a lot of statistics to work with, but there's got to be an impact. And when you look at, for example, and I don't want to pick on NMC, that going from 17 minutes and an 8-minute jump within 2 months, is there a reason for that? I'm not an emergency physician. I don't know, but looking at it from a purely analytical standpoint, I'm curious: is there an impact? Others are relatively stable. The other three hospitals are relatively stable. Why is one significantly higher?
Harry, just to your point, we are looking at that. It's one of the things that we know in the same way that Dr. Greenson made the point of the staffing or the number of ambulances that are in the system, and just as you're making the point about the APOT times, those are things that do have an impact. And so we have to look at that. We cannot, I think that the response time compliance is affected by a number of factors. These are things that we are looking at. As you can see from the data, we are drilling down to learn more and to pinpoint where these things are happening and any patterns that we can identify, and working closely with AMR to see what improvements or changes can be made. The APOT times, we saw the fluctuation, especially with COVID. We know that it started taking longer to get a unit back ready for calls because of the having to decontaminate the unit. Those times, even though they're still having to decontaminate, the APOT times have decreased. Yes, Steve.
So, and I just want to point out, remember, this is a 90th percentile. This is a chart that's always going to be affected by the longest times, because the longer the time, the 90th percentile extends out. And so when you compare it to the next slide, which is the average time, first, this, if we look across the state, are fabulous times.
Mm-hmm.
When you compare it to San Bernardino County, LA County, where their 90th percentiles are almost measured in days. I joke, but it's not that far off. I have a nephew who's just entered the wonderful world of EMS as an EMT down in San Bernardino County, and he's experiencing wall times as we talk of hours where they're being brought multiple meals because they're stuck on wall time. So remember, this is 90th percentile. If we could look at the next slide, you'll notice that when you go with average, and don't go with the chart, because the chart makes it look like, again, look at the nativity. It's 11-minute 51-second for the May, where it was 19-minute 90th percentile. So even though the bar looks as long, it's significantly lower. And this is the average time. Again, also hugely impacted by the outlier times, because when you average it, it extends that. But even then, this is the average time that it takes to get the patient off the gurney. And yes, it does have an impact on response times, but this is a healthy system, you know, looking compared to what's going on in a lot of the state. If that helps any.
And I appreciate that. I know there's efficiencies, but I liken this entire process to a huge medicine ball sitting out there on the field, and somebody goes out and punches it really hard on one side. You don't know where it's going to bulge out on the other side. I mean, our system, there are many factors. I think that's your point, and I really appreciate that. But I think we need to continue to be vigilant to look for anything that could impact late times or cause late times. Let's put it that way. I mean, I feel that we're very vigilant and we're very incisive in our analysis, but we need to keep that up. And I just keep looking for those little things that cause trends.
Thank you, Harry. And we are doing that. We don't want to bring data back to the committee until we have validated, we are sure of what we're bringing. But we are looking at these things. You know, we are looking at the staffing reports, which AMR is sending to us, daily reports submitted to us on a weekly basis of their staffing. We are looking at the APOT times. We're drilling down to see when those things are happening, the delays are happening. We know that it happens it's not happening every day. There are certain days, a single day could be, but just as, you know, Steve pointed out, when you measure it on a 90th percentile, those outliers affect the data a great deal.
Well, yeah, and I appreciate that, Teresa. And I'll keep key to something that Michael said that I think is very germane. It's the practical context. One late call a day is a good benchmark. I mean, that's a practical operational benchmark. Those type of things is what I'm looking at to see if there are trends. And I know the analysis by staff is very clinical in that regard. So I appreciate that. I appreciate the whole process.
Thank you, Harry. I think that concludes my, yeah, the rest is just definition. So that concludes the presentation on response time compliance. I would be happy to answer any questions or have our team help me answer questions.
Okay, I see no questions. Any questions for Teresa? We can, I think Steve was saying you move on to the next one, which is the
AMR fee forgiveness.
The AMR fee forgiveness.
Right. The reason this item's on the agenda is AMR presented their fee forgiveness brochure. The last meeting, it looked really good, but they had, Mike said that it was not quite completed, so it's here just to see if it's completed.
Yeah, and I can give a quick update. My apology, I sent the final version to the EMS agency just last night. So I was late getting the final version, but it's completed, which is good news. So we can start putting that out. And I'll make sure that everybody in the committee also has a copy. I was also able to touch base with our PBS department out of our corporate office. We have the invoices that are sent out to the patients are typically done by state and region. But I was able to confirm that we do have a section on all of the invoices that go out that we will be able to customize. So we can work with the agency and maybe modify some of the language in terms of, providing either a web link or a phone number, or even just having that section of the text, free text box translated into Spanish. So that's the next step, is that we've already taken the brochure. It's already, the request for the Spanish translation has already been put in as well. And I expect that we would have that for your review, hopefully the final version and implemented by September. So thank you for everybody's patience. And we'll make sure that everybody gets a copy as well. Thank you. That's all I have.
All right. Thank you, Mike. Any questions for Mike? All right. We move on to the next report. Other provider response time reports by Roxanne. I think that's been covered.
I am going to request to table this item. Roxanne did work on the changes. As you may remember, at the last EMCC meeting, There was a question whether the data that was being presented included CAL FIRE data. And thanks to Leanne for offering to work with us and to make sure that we validated the data that we had. Roxanne, our team met with her team, and right now I can report that the data that was presented to you the last time did include CAL FIRE data, but I don't feel that I can do justice to the report that Roxanne would have provided. So if it's okay with the committee, I would ask to table this item until the September so that Roxanne can do the presentation to you.
We need a motion for that? No, okay, that's fine, perfect. All right, thank you, Teresa. Moving on to the next, EMS system performance matrix. And under communications testing, Steve, you have a report for us under 800 megahertz ReadyNet, and I think that's it.
Yes, and it'll be hopefully unpainfully brief. So if we could pull up the report. So we had an issue with the 800 megahertz radio testing in that AMR moved their dispatch location from here at Schilling back to the 911 communications center. And for a period of time, the 800 megahertz radio was not set up over there for them to do the testing. So they're, I don't believe we have that report. Oh, the ReadyNet report?
Yeah.
Because the 800 one would have, has a gap. Would you like to share my screen?
Yeah, you can. Yeah, then go for it.
All right, let's see how I can do this. Sorry, I'm working on a single screen, so everything gets buried. I will be sharing my screen here in a moment. I get back to the. Okay, share screen.
There we go.
All right. Second. There we go. Okay, so this is the ReadyNet drill report. And you can see over time, we've had some variability in responses. And, you know, clearly we see one with, I believe Chomp had 1 month where it just sort of fell off. But clearly we've got things back in order. And we'll be looking for, trying to see what we see in the last month of reporting, which is May, where everything is pretty close to our 95% standard that we're looking to do. And so we'll just keep working on that. And unless you have questions, I'm just gonna let it go there.
Okay,
Thank you.
thank you, Steve. Any questions? Seeing none. Okay, thank you, Steve, again. And we'll go to our next item, which is old business. Steve again for EMCC membership.
Sorry, I was just finishing up the last one. All right, as far as the MCC membership goes, we've been working very hard to get all the appointments through with the board and get the oath of offices completed. And for those who scrambled in the last few days to make sure that that got done, we thank you very much. And I think we've got all the oath of offices now for our primary members. We're still working, I think, on a couple of the alternates. So if, I'm sorry? Oh, John Anthony, he's on vacation. He apologized and he'll be doing that upon his return. So thank you for working so hard to do that. If you haven't yet turned in your oath of office, please do so that we can have you available to vote and represent your constituency at EMCC. So thank you.
All right. Any questions for Steve? Look like we have any questions, so we can move on to our next item on the agenda, new business, and we have none. So that, we can check that off, and announcements and for the good of the order. So any member of the committee may make any announcements or comments. And the EMCC may not discuss or take any action on any items raised during announcements except to decide whether to place the matter on a subsequent agenda. So
We have a couple of items.
yeah, I'll turn it over to Teresa for announcement.
Thank you. One, we want to congratulate Chief Craddock, who has been promoted now to chief. We congratulate him at the last meeting. And we also have an announcement that Jeff D'Andra is going to be leaving the EMS agency. His last day with us is Friday, July 16. And we want to thank Jeff for his contribution to the system and everything that he brought to the team. One of his gifts is the way that Jeff builds very good relationships with our stakeholders. And, you know, we love that about him. The MOAC program is being transferred to Deborah Hapgood, who has a lot of experience in that area as well. And yeah, so those were our announcements.
Roger has his hand up. Roger Reinhardt has a hand.
Roger Reinhardt.
Hey, sorry, Tino. I wasn't able to pipe in on the reports. If I could go back for a second, if that's appropriate.
Question?
Yes.
Yeah, go ahead.
Yeah, on section G, I had a question, I guess, for Teresa, since Roxanne isn't here. I had reached out to Roxanne to be able to work with her to provide data for that report. And so Teresa had stated she got the data she needed. I was just curious as to where she got it from, because I never heard from Roxanne. So I just wanted to make sure that we're all on the same page and wanted to close the loop on that.
Okay, can we reach out to you after the meeting? I don't
Absolutely. I didn't want to take up too much time, but I never heard from Roxanne on that report from the last meeting. So I just wanted to close the loop on that.
All right, thank you so much for letting us know. I'll work with Roxanne to make sure that we reach out to you.
Perfect, thank you.
Okay. Thank you, Roger. Teresa, I'll let you continue with your announcements.
That was
it?
Yes.
Okay, thank you. Dr. Burley, do you have anything for?
No, nothing new.
Okay. Scott?
I want to thank Jeff again for all his hard work. He made our PPE supplies happen. And without that, we wouldn't have been able to provide the care that we were able to. Thank you. You're going to be missed.
Thank you. Oh, shucks. And, you know, I'll say one thing, which was I left the field as a paramedic in 2014, went off to get some education, did a couple things and came back. And it's been, I don't even know how to describe it, like to see Tino as ops manager and you in your position, and good to see you again, Jody, by the way. And just, you know, half of you up on the board there I've worked with in various ways. And yeah, this is a great EMS community. And I hope, you know, just when you have a quiet moment, you reflect on like what, you know, really is a great professional community that's going on here in this little old county. You know, it's not a big metropolitan area that people don't think about, but yeah, it's happening here. And I'm honored again and proud to have worked with you guys again. So thank you.
Okay, well said, Jeff. Thank you. Any other announcements from the committee folks? All right, I don't see any. All right, well, we'll move to close out the announcements, and our next meeting is scheduled for Wednesday, September 8th, 2021 at 10:30. More information will follow from the EMS agency. So that is it. And again, from my end, thank you, Jeff, again for all your work you're doing, and you know, work with you soon. Okay. All right. Well, that concludes our meeting. We can adjourn unless we need a motion for that. I think we don't. So meeting's adjourned. Thank you, everyone.
Thank you, Tina.
Thank you.
Thank you.
Thank you.
Have a good day, everyone.
Take care.